It is my pleasure to host for this Ask the Author session, Professor Andrea Casadei Gardini, who is working in Milan, who will present his recent publication entitled Lenvatinib versus Sorafenib, second-line therapy in patients with HCC progress to Atezolizumab, a retrospective real-world study. First of all, congratulations, Professor Casadei Gardini, for this publication to you and your co-authors. Can you tell us what is the background of this work?
Thank you for this kind invitation. The results and the Celestial trial lead to the approval of two TKIs, respectively regorafenib and cabozantinib after first line with sorafenib. Sorafenib was the standard of care in first line during the enrollment of these two trials. Now we know that sorafenib is not the best choice in first-line setting, and the most frequently used first-line treatment in patients with advanced ACC is Atezolizumab plus Bevacizumab or STRIDE. After first-line immunotherapy, there are no randomized studies that allow us to evaluate the best treatment sequencing for our patient. Upon progression after this treatment, the standard of care in many countries is sorafenib due to the lack of reimbursement of other drugs after immunotherapy. Several randomized trials are currently underway to clarify the best second-line therapy for patients with advanced ACC after immunotherapy. Waiting for this data, this is a retrospective multicenter real-world study aiming to compare outcome reached by lenvatinib and sorafenib second-line therapy in patients with ACC progressed to first line with Atezolizumab plus Bevacizumab.
So what is the design of your study?
The design is very simple. The study population derived from a retrospective analysis, but of consecutive patients treated with Atezolizumab as a first-line treatment for advanced ACC or intermediate ACC not eligible for curative treatments. The overall cohorts include the Western and Eastern patient population from 46 centers in 5 countries, Italy, Germany, Portugal, Japan, and the Republic of Korea. The endpoint of this study was to compare median overall survival achieved by sorafenib and lenvatinib second line, and we evaluating the overall survival from the start of first line. The choice of second line drug was left to the treating physician.
So, what are the most important results of this study?
So the overall cohort include about 900 patients treated with Atezolizumab. Of them, 53% of patients had a progressive disease, and about 50% of patients with progressive disease received a second-line treatment. Of them, 51 received sorafenib and 86 received lenvatinib. Lenvatinib second-line subgroup achieved from first line a median overall survival of 18.9 months, significantly longer compared to sorafenib group that reached a median overall survival of 40.3 months. The hazard ratio in favor of lenvatinib was 0.48. In univariate analysis, in addition to lenvatinib second-line therapy, we highlight the predictor role of ALB grade 1, the absence of portal vein thrombosis, having received at least one previous local regional procedure, and this category was highlighted the predictive role in terms of overall survival. We perform multivariate analysis, and after multivariate analysis, we confirm that ALB1 grade and lenvatinib second-line therapy has a positive prognostic factor for overall survival. In addition, the forest plot highlight a better overall survival of lenvatinib compared to sorafenib in male patient, age less 17 years, viral etiology, BCLC stage, alpha fetoprotein less 400, child PAG A, and neutrophil lymphocyte ratio less 3. The iteration test did not show any predictive factor for either second-line therapy. Finally, no different were found in terms of progression-free survival, response rate, and disease control rate between two drugs.
So, with all these results, how do you see the impact of this publication on our practice?
So, in my opinion, is one of the first publication that demonstrate that in the first point that half of patients receiving first-line atezolizumab plus bevacizumab have access to second-line treatment after progression disease. But the most important result is that our studies suggest that lenvatinib second-line therapy is superior to sorafenib, regardless of patient baseline characteristic. Clearly, we're waiting the result of phase 3 trial in second line, but now, after this paper, I think that the best choice for our patient is lenvatinib and not sorafenib second line after immunotherapy.
Thank you very much, Professor, for sharing all this data on your thought about this paper, and congratulations again for it.
Thank you very much for all.
Be part of the future and join our fight against liver cancer.